Get our recording started and kick off our meeting. So welcome to the virtual family council meeting. My name is Jamie Rose. I'm your virtual family council coordinator. And we're going to start the meeting off by reviewing our confidentiality reminder. Please refrain from using the name of your loved one. Do not name specific facilities. Please use a nursing home or the personal care home to present to the group. If you need specific assistance, please use the chat feature to state which county you are in, and we will get you connected to your assigned ombudsman. These calls have public access and are designed for family members and friends of residents in long-term care facilities. We'll review our meeting agenda. We're going to get our virtual meeting tips from Eliza, and then we'll kick it over to our presenter for this evening, Toby Edelman, and then we will round up with our upcoming meeting topics. So I'm going to pass it to Eliza for our virtual meeting tips.
Hi, everyone. I am Eliza, and I'll be sharing your tips with you this evening. You all have been placed in mute upon entry to the meeting. We will open those lines in a bit so that you will all be able to share. If you would like to speak or if you have a question, please use the raise hand feature. Once your hand is raised, we'll acknowledge you and we will unmute your line for you. If you hover over your mouse at the bottom of the screen, you will see the participants tab. You can expand that tab if you would like to see who all is in the meeting with us this evening. The chat feature is also at the bottom of your screen as well. Once you maximize it, you'll be able to chat with the presenters and other people in the meeting this evening. We will be using polling questions during the meetings. You will simply click on the answers that you'd like to select and hit submit. If you do need to step away from the meeting for any reason, you can stop sharing your camera by just clicking on the camera icon at the bottom of the screen. And then when you return to the computer again, you can just re-click that camera button and that will share your photo again. And then as always, any concerns or complaints can be directed to the State Ombudsman Office at 717-783-8975. Or you can email us at ltcombudsman@pa.gov. So I am going to turn this over to Corey Oh, I'm sorry, Corey, I totally fumbled your name there, Corey, and she is going to introduce our speaker this evening.
Thank you, Eliza. Joining us this evening is Toby Edelman. She is the Senior Policy Attorney for the Center for Medicare Advocacy. So she has some really important information she's going to share with us. Whether we need it currently or will in the future, it's really great information to share. So thank you, Toby.
Sure, thank you. I'm so delighted to be here with you, and thank you for inviting me. Next slide, please. The Center for Medicare Advocacy is a national nonprofit law organization, and we try to get comprehensive Medicare coverage for people. And we do that through a variety of methods, talking to people, doing webinars, writing, litigation. So what I want to talk about today is a few things: Medicare coverage and appeals rules, observation status, and JIMO, confirming that coverage for maintenance nursing and maintenance therapy. Next slide, please. So just briefly, what are the resources? What we have here is the Medicare law, which is 42 U.S. Code, that stands for U.S. Code, Section 1395. The regulations, 42 Code of Federal Regulations with the numbers, and then the Medicare Benefit Policy Manual with a link to that. And that gives more detail about what the law and the regulations say. The chapter that is relevant for nursing homes is Chapter 8. It's the nursing home chapter, but Medicare calls it extended care. Next slide, please. So the basics for coverage of care in a skilled nursing facility are first that a person be in an acute care hospital for at least 3 consecutive days. The way Medicare counts time is that it counts midnights. So it's 3 days, not counting the day of discharge. So for us, the shorthand is 3 midnights as an inpatient. Then the person needs to go to the hospital within 30 days of discharge from the hospital. A physician has to certify that the beneficiary needs care in a skilled nursing facility. And that means either daily skilled nursing services or rehabilitation services. The facility needs to be certified for Medicare, and the person needs inpatient care. Next slide, please. Care has to be reasonable and necessary and require the skills of professional personnel, registered nurses or therapists. Care has to be daily. Skilled care must be daily. Nursing it 7 days a week, or rehabilitation 5 days a week, or combination of nursing and rehabilitation 7 days a week. So if somebody got therapy 3 days a week and skilled nursing the other 4, that would count. The 3-day qualifying hospital stay means that the beneficiary has to be in the hospital, in the acute care hospital, for 3 days. This is a little bit odd to me. This PowerPoint looks different from what I have in my hand, so I'm a little bit confused, but we'll just keep going. So 3-day qualifying stay. Next slide, please. Now, during the pandemic, the coronavirus pandemic, for the last year, there have been 2 big changes to Medicare coverage. The first is the CMS, the Centers for Medicare and Medicaid Services, which is the name of the agency that administers the program. CMS waived the requirement for a 3-day inpatient hospital stay. There doesn't have to be any connection at all to COVID. It's not necessary that there be any connection, but a beneficiary can go from the hospital after 1 day, 2 days, no days at all, can come directly from the community into a skilled nursing facility and it would still be covered if the person meets the other requirements for Medicare coverage of a stay in a skilled nursing facility. So needing skilled services 7 days a week, physician certification, all of those requirements still apply, but not the requirement that the person first be in the acute care hospital. Next slide, please. The second change is very strange. This is really a different PowerPoint. I might have to, I don't understand why this happened, because I thought this PowerPoint that I have in my hand, and it's quite different. But let me just tell you, the other change in Medicare coverage is that during the pandemic, even though the benefit ordinarily is limited to 100 days, during the pandemic, a nursing home can ask for an additional 100 days if the person still needs skilled care, and the reason for the extension of the benefit period is related to the COVID pandemic. So we have a toolkit, and I'm going to resend the slides afterwards, but we have a link to a toolkit that our office put out about what to do to try to get the additional 100 days. So seems to have left observation entirely, which I thought we were. Let me just talk about it briefly, even though it's not here in these slides. What we mean by observation status is that somebody is in the hospital for multiple days and nights, receiving medical care, nursing care, tests, medication, therapy, but the person is not called an inpatient. The person is called an outpatient. And if the person is an outpatient, not an inpatient, then that does not qualify the person for Medicare Part A coverage in a skilled nursing facility. The person must be called an inpatient. Now, Medicare Advantage plans have the right to waive the 3-day inpatient stay, and mostly they do, but sometimes they don't. So it's still something you need to pay attention to. Beginning in 2016, the federal government, from a law called the Notice Act, Notice of Observation, Treatment, and Implications for Care Eligibility, required for the first time that hospitals tell people that they're in observation and not inpatients. And they have to get a notice called the MOON, the Medicare Outpatient Observation Notice, which tells them that they're outpatients and what the consequences are. One problem with the notice and with the regulations is that they say that there is no appeal right. There's no other notice that people get in Medicare that says you have no appeal rights, but that's what happens with the MOON notice. If people get it, and not everybody is getting the MOON, you have no right to appeal. So we are trying to deal with other things to deal with observation. We have a lawsuit that we filed in 2011, now called Alexander v. Azar. That is a nationwide class action, so it affects everybody in the country. And what we're trying to get in that case is appeal rights. There is a change. If a person has been changed from inpatient to outpatient while the person was in the hospital, and the facility is required to give the person a notice that says that, then under the settlement or under the court order, they might have a right to have a hearing. Now that's under appeal and it's very confusing, but if anybody since January 1st, 2009 was in the hospital as an inpatient and then got switched to outpatient, so as a result of that switch, they no longer had a 3-day inpatient stay, they might be able to benefit. So please call me and we'll try to figure out what to do about it. We'll check with our lead attorney on that case, who is trying to get a system from the federal government about how to appeal. The only other thing I wanted to say about observation is that there's legislation in Congress, and it's been there almost a decade now, gets reintroduced every new Congress. So it has to get reintroduced this year. And what it says is very simply, one sentence: if you're in the hospital for 3 midnights, whether you're called inpatient, outpatient, observation, whatever you're called, you've met that requirement for Medicare coverage of a skilled nursing facility. As long as you're in for 3 midnights, they all count regardless of what the hospital calls them. Okay, so now we'll go on to Jimmo, and maybe just be the same slides that I have. Next slide, please. There has been a myth for many years among healthcare professionals, nursing homes, the reviewers, the Medicare contractors, that Medicare will pay for care only if the beneficiary is actually expected to improve. Now, this is not true, and it has never been true. Next slide, please. The regulations that I was telling you about before, the Medicare regulations for nursing homes, say even if full recovery or medical improvement is not possible, a resident may still need skilled services to prevent further deterioration or preserve current capabilities. Now that seems pretty straightforward, right? Next slide. But despite this unambiguous language, people are denied coverage. There's another regulatory provision when the specialized knowledge of a qualified therapist is required to design and establish a maintenance program based on an initial evaluation and periodic assessment, that is still covered. Next slide, please. But the important point is whether the skills of a therapist are needed. Next slide, please. So even though this language has been very clear in the regulations and now in the guidance in the Medicare manual, residents are frequently and still denied Medicare coverage because they're not expected to improve. And we had represented a lot of people about this in individual cases. In our Connecticut office, where our main office is, they represent people, but only in Connecticut. They represent people directly. And they had a number of cases like this. There were 2 federal court cases rejecting the improvement requirement, looking at the actual language of the law and regulations. There was a case in Pennsylvania, a nursing home case, and a home health case in Vermont. And we decided it was time to take this issue on head on. Next slide, please. So in January 2011, we filed the lawsuit called Jimmo v. Sebelius, who was then the secretary of HHS. And we were trying to eliminate the actual use of the improvement standard in nursing homes, home health, and outpatient therapy. We settled the case in 2012, and then 8 years ago, a little bit more than 8 years ago, in January 2013, the judge approved that settlement. It's a nationwide class action, so it affects everybody in the country in each of those care settings: skilled nursing facilities, home health, and outpatient therapy. One thing that we did that we don't usually do was sue on behalf of a number of organizations that are listed here, like multiple sclerosis and Parkinson's and cerebral palsy. The point of having organizations of people representing people who have chronic conditions is to say, if you have a chronic condition, it's not going away. You can have all the therapy and all the nursing care in the world, but MS doesn't go away. It's chronic. It's not an acute care condition, an acute condition. But that doesn't mean people don't need Medicare coverage to maintain their function, to maybe slow down the decline or deterioration. And that was the point of having those organizations, and that was the point of the lawsuit. Next slide, please. So JIMO applies not only to people in traditional Medicare, but also to people in Medicare Advantage plans. Medicare Advantage plans have to use the same coverage criteria as traditional Medicare. They may offer more coverage than traditional Medicare, but they can't offer less. So they are bound by the same standards, the same coverage criteria. So Medicare pays for services if a person is expected to improve, or if the professional services are necessary so that the beneficiary can slow the decline or deterioration of the beneficiary to maintain function at the highest possible level. Next slide, please. So what the settlement of the case means that the judge approved is that facilities or home health or outpatient therapy cannot deny coverage by saying the person isn't improving. They can't say the person is stable or has a chronic condition. Those are not reasons to deny coverage. They can't say you're not expected to improve in a reasonable period of time, so Medicare won't pay. Wrong. That is not the standard. Services can be skilled and they can be covered even when the person has plateaued or services are maintenance only to maintain function, prevent decline or slow decline or deterioration. Next slide, please. So the questions that are relevant to ask are, is a skilled healthcare professional, either a nurse or a therapist, physical therapist, occupational therapist, speech therapist, is the service of that healthcare professional necessary to ensure that the nursing services or therapy services are safe and effective? Does the person have to either provide the care directly or supervise the care? And if the answer to those questions is yes, then Medicare will cover the care in skilled nursing facilities, home health, and outpatient therapy, whether the care is necessary for the patient to improve or to maintain function or slow decline or deterioration. Next slide, please. So facilities can't say, you're stable, you're chronic, you're not improving, you don't have any restoration potential, you need care for a long time. That's especially important in home health because there are no limits in how long you can receive home health. There is a legal limit for skilled nursing facilities, as I said in the beginning, 100 days in a benefit period, but that is waived, or it can be waived at the request of the facility during the pandemic. But that's the only time that any of these healthcare providers can say, we're going to deny Medicare coverage. If it's in the law, which the 100-day limit is in the Medicare statute for skilled nursing facility, that is acceptable. But to say it for home health, no, it's not relevant for outpatient therapy either. Next slide, please. So what's also relevant is, what does this particular person need? We're not asking what do most people need, what do other people who have that same condition or similar disease, what do they need? We're saying it's not appropriate to look at a diagnosis or a treatment norm. This is all an individualized assessment. What does this person need? Looking at the combination of medical conditions, whatever is going on with this person, what does this person need? Not what do most people need or some people need, not relevant. Next slide, please. So after we settled the case, the government was required to revise the manuals, and it revised the chapters for each of the care settings that were covered by the settlement. Skilled nursing facilities, which is Chapter 8, home health, outpatient therapy, and a little bit different for another category called inpatient rehabilitation facility. CMS clarified that skilled maintenance therapy and skilled maintenance nursing are covered by Medicare, and they eliminated any of the conflicting provisions in that manual. So this was published as a transmittal January 2014. Next slide, please. Now the next few slides are some of the reference slides that I talked about at the beginning. I don't want to go through them, but they will give you an idea of what to do if you are in an appeal, because they tell you how the Medicare benefit policy manual looks at this information. How does it analyze and try to understand what's going on with patients? So let's skip the next slide. And then this one I wanted to talk about, because look at this. This is a very specific example of coverage. An 81-year-old woman, and then all of her medical conditions are described. Confused, hemiplegia, congestive heart failure, atrial fibrillation, on and on. But then it says, even though no specific service provided is skilled for this person, the patient's condition, taken as a whole, requires daily skilled nursing involvement to manage a plan for the total care needed, to observe the patient's progress, and to evaluate the need for changes in the treatment plan. So you can see how very specific and detailed it is. Next slide, please. So here's an example of another one. Possibility of adverse effects from improper performance of an otherwise unskilled service does not make it skilled unless there's documentation to support the need for skilled service. So you might want to look at these if you're in the appeal, to go back to Medicare Benefit Policy Manual and see specifically how it analyzes the situation, how it tells the people who are making decisions, the nursing homes, how to decide if somebody needs skilled care or not. Next slide, please. So what the manual says is that what you get from the manual is that it has to be specific, a detailed description of the resident, and an explanation of why that person actually needs skilled care that Medicare will cover. Now, in the manual, CMS emphasized a lot of documentation. That was not required actually by the GMO settlement, but the government took the opportunity of revising the manuals to really emphasize the importance of documentation. What's important to know is that the care plan needs to describe in detail the resident's need for a maintenance level of care. We can't just assume that after somebody's improvement stage ends, the person automatically will transition to maintenance coverage. It doesn't work that way. There has to be documentation in the care plan that the person needs the skilled services in order to maintain function or prevent or slow decline or deterioration. If somebody like me could provide the services and that would be sufficient, I'm not a healthcare professional, that would not entitle the person to Medicare coverage. Need to require the services of the healthcare professional, the nurse or the therapist. And the other important point is that people can shift from maintenance to improvement, as well as from improvement to a maintenance level. It depends. So sometimes when people have a hip fracture, when they're in the nursing home, some physicians say, don't want you to have therapy until you are weight bearing again. And so they might be in a maintenance level for upper body maintenance. And then when the person becomes weight bearing, then they're in improvement mode for therapy. So it depends, but it depends upon what that person needs and what the facility documents clearly in the manual. Next slide, please. So following the settlement in GMO, the government actually did what it was required to do. It made the manual revisions, it conducted training. We met with them several times in Washington. But even though we had this settlement and they had done they had done what they said they would do, what they were ordered to do, there was a lot of noncompliance. And we heard about this across the country and in all of the care settings. And that's because there was still the belief among a lot of providers and adjudicators that Medicare coverage is limited to beneficiaries who are improving. One daughter told me that the therapist in her mother's nursing home said, "I've been a therapist for 35 years. If you're not improving, Medicare won't cover your care." Well, that's not true, but a lot of people believe that. And so we had this ongoing problem. Next slide, please. The biggest obstacles to implementation following the settlement is the belief that, you have to be improving. And then what would happen is that the nursing homes would typically say, "We're not going to give any more therapy." Even though the physician is saying it, the surgeon, the primary care physician, they just stop providing the services that were ordered. Next slide, please. SNF's continued excuses for non-coverage are, from our perspective, usually not valid. The SNFs may argue that the person has plateaued when in fact the person really just needs more time to improve. It takes a long time. They're not going to bounce back in a week. It might take 2 weeks or 3 weeks. I know one son told me that this is what the nursing home had said, "Your mother isn't improving." He got all the way through to the administrative law judge hearing. And at the end, the judge said, "How is your mother doing?" And he said, "She's going home tomorrow. She's walking out." She needed more time than the nursing home originally thought she needed. And he won his appeal. The judge said, "Yep, Medicare will pay for that entire stay." It took more time than the nursing home thought. So she hadn't really plateaued. She hadn't really stopped improving. It just was taking time. Sometimes a resident might be depressed or upset and not want to participate. A person might be sick, have a fever or a UTI, and be temporarily unable to participate in therapy. But that doesn't mean that the person isn't going to feel better, feel psychologically better, and start participating later. So we know that improvement doesn't necessarily just go upward constantly. Sometimes people are stable, they might even decline and then improve. They might plateau, but it doesn't mean that they aren't entitled to Medicare covered services. And also facilities sometimes say it's residents' right. Well, yes, residents do have a right to refuse treatment, including therapy or services, but that's usually used more as an excuse than as a real effort to talk to the resident and try to persuade somebody that this will be a good thing to go to therapy today. I know it's been especially hard as families are barred, because a lot of times families are able to support and encourage the use of therapy, and that hasn't happened. So that's been very difficult now, but it's not sufficient for the facility to say residents' rights not to participate in therapy. Next slide, please. So we were frustrated and we thought, we won this case, we settled it, the government did what it was supposed to do, but nothing has really changed sufficiently. And we went back to court. We went back to court in March 2016. Next slide, please. And what the judge did was rule for us to some extent, and she ordered some corrective actions. So there were a lot of things she said they had to do. Next slide, please. This is probably the most important. The important message from Medicare that she ordered them to post, and actually what they wound up posting is what she ordered them to post that we had written. So that was pretty good. It's on the dedicated webpage. And it's in the transmittal message notifying stakeholders of the webpage. This important message from Medicare, which says some facilities may have been under the misinterpretation that people had to be improving to qualify, and that's not true. And that's what the important message says. And next slide, please. So this is the GMO homepage. Now, I was saying before, I had actually checked all the links, but since this is not the correct PowerPoint, I'll have to send the correct one. It's similar, but a little bit different. I don't believe I checked this particular link for the GMO homepage, but if you put in the search engine, in a Google search engine, GMO settlement, the JIMO homepage will come up. So the first thing is this big blue box, the important message from Medicare. And then there are links to a lot of resources. And there are frequently asked questions, and we'll look at a few of them. And what we suggest is that that's linked on this homepage to Chapter 8 of the Medicare Benefit Policy Manual, because what that version has, the transmittal version, has all the changes made by the settlement in red italics. So it's a very clear visual image that there were changes made by JIMO, because a lot of what we were hearing from facilities is, well, we didn't, the regulations weren't changed, the law wasn't changed, nothing changed, so we were doing the right thing. Our interpretation was right. And our response was, no, your interpretation wasn't correct, that people needed to be improving. That was not correct. And here, if you look at Chapter 8 with the red italics, you can see all the changes that talk about maintenance coverage. So that's a very clear visual way of explaining to facilities that there has been. Next slide, please. So I wanted to look at a couple of the frequently asked questions. Question 7 talks about what I said before, that people can change from improvement to maintenance goals and vice versa, from maintenance to improvement goals. Question 9 says that different therapy disciplines, physical therapy, occupational therapy, speech therapy, can have differing goals. Somebody could be in an improvement mode for physical therapy, but in a maintenance standard for occupational therapy. So each discipline could have a different goal. Next slide, please. Question 11 is really an important one. CMS says explicitly, Medicare does not require a patient to decline before covering medically necessary skilled nursing or skilled therapy. That's a really important frequently asked question, because what a lot of families were told was, well, we don't think she's qualified now, she's plateaued, your mother isn't getting better, but if she declines, then maybe we could start Medicare up again. No, Medicare does not require people to decline. We're trying to keep people functioning at their best possible level, what's best for them. So that's an important, notable, frequently asked question. Next slide, please. So we submitted questions ourselves. We submitted FAQs to CMS. Some of them they accepted, some they didn't. They wrote them in their own way, but we have a link to what we were suggesting. Next slide, please. So what do we tell people to do if Medicare coverage is denied? And this is probably the important part. First, the most important thing to do is, if at all possible, to have the physician on your side. The physician is the best and most important ally to order care and to keep the services in place. So you want to do whatever you can to get covered services ordered and actually provided. Because if the person doesn't get skilled care as covered by Medicare, then Medicare won't pay. If it gets to an administrative law judge and the judge said, well, yes, your mother needed the services and she was qualified, but she didn't get them. So you didn't get them. So I'm sorry, Medicare will not pay. You have to have gotten the services in order for Medicare to pay. What we suggest to people is that they use the JIMO settlement, the regulations, the manual, the homepage, the JIMO homepage and materials, and a number of self-help packets and materials that we have that are linked at the end of the PowerPoint. And if unsuccessful, use the appeals process. Another thing you can do is go to another nursing home. They can do their own analysis. Now, that's very difficult, easier said than done, but it is a possibility that people could go to another skilled nursing facility. Next slide, please. So what we suggest doing is appeal, use the expedited appeal to keep services in place. And if that doesn't work, use the standard appeal, and that is to get Medicare payment for services that have already been provided or that are being provided. We'll talk about that in a couple of minutes, some of these different appeals. Next slide, please. The most important thing, again, is to have the physician supporting you. So if there's a primary care physician or some other physician who's been treating the resident, like the surgeon, somebody had hip surgery and the surgeon will have some position about what should be done for the patient. See if one of those physicians will talk to the nursing home, talk to the medical director to explain why skilled care is necessary for that physician's patient. The other thing to do is to ask the physician to write a specific detailed letter explaining why the patient needs skilled care. And I sent to Corey a couple of examples. One was an example of a doctor's letter that actually persuaded a skilled nursing facility to provide 30 more days of Medicare coverage. So I asked the daughter to send it to me and we redacted it. We have that. I also sent Corey a template that a private attorney did based on a couple of these letters to pretty much fill in the blank. Sometimes doctors aren't sure what to write. They think if they just order it and they say, well, I'm telling you to provide skilled care to my patient, that will be sufficient. That's usually not sufficient. That isn't going to work. You really need a detailed letter. So the first letter that we have, these are the things I think the letter needs to do, and the template sort of has the fill in the blank to do it. The doctor needs to explain the relationship to the patient. If there's a lengthy relationship, that would be good. Explain the medical conditions, what the resident needs. Then we want the doctor to say what the person actually needs and why, and if possible, explain why this patient is likely to benefit from the services that the physician is saying are necessary. So if you get a letter from the physician, sometimes families try to fill in the blanks on the template and give it to the physician. I mean, you would ask the physician, would you like a template? Would that be helpful to you? Would you like me to write something? Sometimes people want it, the doctor wants to do it individually. Sometimes they say, yes, fill in the blank, let me look at it, and then I'll see what I want to write. But it's useful to have a letter if the physician, especially if the physician can't get on the phone with the skilled nursing facility's medical director. The letter could be useful, sometimes in persuading the facility, and certainly for appeal. You would want to submit this letter for appeal. Next slide, please. The other kind of documentation you want for an appeal is something written by a family. And I sent Corey a couple of letters that a daughter wrote explaining how much therapy her mother had received, how the resident had actually improved when she saw her from getting the therapy, how much family involvement there had been or not been in her case in care planning, and how the Medicare Advantage plan had pretty much prejudged how much therapy her mother was entitled to get. Now, I know it's much more difficult during the pandemic when families have been barred from facilities to have a family documentation of therapy going on. But if there's anything that the family can write about a prior situation where the resident had received therapy and benefited from it, whatever you can say that's based on personal knowledge, what you've observed, what you've seen, what you know, you can submit that. Next slide, please. So the evidence to submit on appeal, the factual evidence is the physician support letter, any family statement, and whatever else you can develop. Sometimes you might want to have a statement from a so-called expert witness, another physician or a nurse, somebody who reviews the medical records and says, this is why this resident needs skilled care and why. This is what the person needs and why. And sometimes there could be articles in the research literature about the resident's condition. So I know one family was arguing about outpatient therapy for their adult son who had traumatic brain injury. And the therapist attached to her statement that the family submitted copies of articles talking about how people can improve many, many years after a traumatic brain injury. They're still able to improve, and that can happen. And so that, if the therapist has evidence like that to submit with the statement, that could work too. So those are important things to submit for an appeal. Next slide, please. You want to submit as much evidence and legal argument as early as possible in the process. But if people are not being represented by an attorney, then you can submit additional evidence at any time. And families can definitely represent their relatives and friends on appeal. Attorneys are not required. There's really not a lot of law here. This is all about fact. And, the families and friends know more about what the person needs, certainly than the attorneys. That's not really what they're going to know. And the benefit of doing it yourself is if you get additional evidence, takes a little bit of time to get through the appeal and go through these different levels of appeal, you could still keep submitting additional evidence. If you get more later, you could submit it to the administrative law judge. So that's an advantage of representing your relative or friend yourself. But submit as much as you can as early as possible, because maybe you can win at an early level. Next slide, please. So the legal arguments that you would make, not really a lot of law. You want to say, if it's the JIMO settlement that's relevant, my sister needs these professional services, the nursing services, the therapy services to maintain function. Otherwise, she will go downhill. You want to cite that. You want to cite the JIMO webpage and materials, and any of the self-help materials that we have. Feel free to use them, of course. And there's a legal argument that I'll mention when we get to the appeal section, that if the facility doesn't give the right detailed notice in the expedited appeal, then the facility's effort to discontinue Medicare coverage could be denied by the Quality Improvement Organization. Certainly, the burden of proof is on the facility to show that the person no longer needs skilled care. The burden is not on you. It's not on the family. It's not on the resident. It's on the facility to show that the person no longer needs skilled care. Next slide, please. So what happens if the facility stops providing therapy? Because this is what typically happens. Well, one thing to know, and it's not what we want to have happen, but it can help you, is that if there's a break in therapy, say, and the person is no longer getting physical therapy, the person could resume the Medicare benefit period and get Medicare coverage as long as there isn't more than a 30-day gap from the date that Medicare covered services were stopped. So suppose, January 1st, they say Medicare isn't going to pay. They stop services for 2 weeks, but they decide, oh, well, Mrs. Smith has declined. We think Medicare would cover now. She could resume her Medicare benefit period on January 16th, and she would pick up wherever she left off. So if she had 45 days in her 100-day benefit period, then after this 2-week break, she'd be on the next day, day 46, whatever the next day is. You can resume the benefit period so long as that there isn't more than a 30-day gap from the date that Medicare covered services were stopped. The other possible thing to think about, which is also extremely difficult, I understand, especially during the pandemic, but people do have a right to go to a different nursing facility, and that second facility can make its own determination of whether the person is eligible for Medicare and whether Medicare will cover the stay. So you could in fact go someplace else, and you'd be resuming the benefit period. That's the same thing. You wouldn't be starting from the beginning. You wouldn't get a new 100 days. But if the person had used 45 days, goes to a different skilled nursing facility that says, yes, we believe you are covered, the person would start with day 46. Next slide, please. So now we want to talk a little bit about the Medicare appeals and what to do and what these levels are. So the first point is that denial can occur in different ways. Sometimes it's the skilled nursing facility that says, we don't believe that Medicare is going to pay anymore. We think this is not a Medicare covered stay. We used to hear about this on day 21 in particular, because day 21 is the day that the large copayment begins. You know, Medicare pays the first 20 days in full. Day 21, there's a large copayment. A lot of facilities would say, oh, Mrs. Smith has plateaued now, it's day 21. So it could be the facility denying coverage. A second way that denial could happen is that the facility believes coverage is available and submits the claim to Medicare and says, please pay for Mrs. Smith. And Medicare says, no, we don't think that was a covered stay. That could happen. That's a second way that coverage could be denied. A third way is that Medicare Advantage plan, which uses pre-authorization and usually has authorizes care in like 5 or 6 day chunks. They might say, well, you've had 10 days. We don't think you need any more coverage. We are not approving coverage after day 10. That can happen. These appeals start in different ways. There are different notices that we'll talk about now, but after the initial step, the levels of appeal are generally the same. They're identical. So next slide, please. Here are the levels of appeal, and it is crazy. There are so many of them. Redetermination, reconsideration, administrative law judge, Medicare Appeals Council, Federal District Court, and Federal Court of Appeals. They are numerous and a little crazy. So next slide, please. Of course, the key barrier for an appeal is that the beneficiary must have actually received the level of care that Medicare will cover. Therapy either 5 days a week or skilled nursing care 7 days a week or a combination. So what we have essentially with Medicare is pay and chase. You've got to make sure that the either the facility is getting Medicare to cover it, or you are agreeing to pay for the care and then say to Medicare, well, wait a minute, you should pay for this. This was a covered level of care. But if the person does not receive the covered care, the problem is Medicare, there's no point in an appeal. Medicare will not pay for the stay. Next slide, please. Now, these are the barriers, of course, that facilities discontinue therapy and they stop doing Medicare-related assessments of the resident. Now, with the new patient-driven payment model, which is the new reimbursement system that went into effect October 1st, 2019, skilled nursing facilities were no longer required to do additional assessments. So that problem has gone away, but the big issue is that facilities typically discontinue therapy. The other problems we see is that lower levels of care seem largely to rubber stamp non-coverage decisions. And we know most people give up, and in fact, very few people ever appeal at all. But we know if you do keep appealing and try, you have a better chance at the administrative law judge level because you can talk to the judge and explain what happened and why the person you care about was receiving Medicare covered care. Next slide, please. Now, one thing that's very important to know is that the Medicare coverage is not the same as saying that the person has to leave the facility. Facilities will typically say you're being discharged from Medicare, discharged from Medicare. That's a strange expression because it sounds to me like discharge from the facility, but that is not true. Even if Medicare is not paying for the stay, that doesn't mean the person has to leave. The resident has rights under the nursing home reform law, which limits permissible reasons for transfer, requires written notice, gives an opportunity for an administrative hearing. It's a whole separate part of the law that gives totally different and additional rights to residents. So whether Medicare pays is one issue, whether you have to leave the facility is a separate issue. Now, if Medicare is not paying and person loses the appeal, there has to be a different source of payment or a permissible reason under the reform law for discharge from the facility is non-payment. But if the person has Medicaid and Medicaid is paying, or if the person is private pay, those are other sources of payment. So transfer and discharge rights apply, and discharge from Medicare is not the same as discharge from the nursing facility. Next slide, please. I wrote about this in something that we call Center for Medicare Advocacy alerts. These are issues or comments that we write, or explanations of the law or interesting issues, whatever we think is important for Medicare, and it's posted free on our website. These things are all free, and that explains the different rights: discharge from the facility and discharge from Medicare. Next slide, please. So if the skilled nursing facility is the decision maker that's saying, we believe Medicare will not pay for Mrs. Smith's care, then they have to give the person a notice of Medicare non-coverage. This is the facility's decision that Medicare will not be paying for the stay anymore. And this is typically what happens after day 20 or sometimes earlier now. Next slide, please. If the facility makes that decision, there are two kinds of appeal. There's the expedited appeal and the standard appeal. And these appeals have different notices and they have different purposes. This is extremely confusing. And I had a very, very lengthy conversation a couple of years ago with one of our people in Connecticut who specializes in appeals. And we worked this through and agreed that it was crazy and complicated and confusing, even to some of the administrative law judges who will issue rulings that they don't legally have the authority to issue in the expedited appeal. So it's a very confusing situation, but these are very, very different notices. And this is a document, there's the link here, from the federal government, from CMS, explaining these different notices and appeal rights for beneficiaries. Next slide, please. So the first slide is, the first appeal is the expedited appeal. And the purpose is to keep Medicare covered services in place so that Medicare will keep paying. The facility has to give the resident notice at least 2 days before discharge from Medicare, before terminating all Part A services. And so here's the link. It's the Notice of Medicare Provider Non-Coverage. You can click on it and click on the downloads, and that will tell you where the form is. Now, the problem is the resident has to call the Quality Improvement Organization by no later than noon the following day, which is why it's very difficult to do, because you don't really know the basis for the denial of coverage. They just give you this notice, and you'll see from the next slide that it's confusing. So the Medicare covered care continues until the day of discharge that the SNF identifies, unless the Quality Improvement Organization reverses that decision. But if the facility doesn't give the right information to the QIO, then it's going to lose its decision that the person has to leave. Sometimes the QIO finds that the notice was not valid, and then coverage continues. But again, the burden of proof is on the skilled nursing facility to prove that services should be terminated, that Medicare will no longer pay. Next slide, please. Now, the QIO has to do a lot of things when it gets this notice. It has to see if the notice was valid. It has to look at the records that the nursing home submits. It has to ask the beneficiary who requested the expedited hearing, what is your position? What do you think? It has to provide an opportunity for the provider or practitioner to explain why termination of services was appropriate. And then within 72 hours, it has to notify the beneficiary, the physician, and the skilled nursing facility. Next slide, please. The facility has responsibilities too in the expedited appeal. So the QIO has to notify the facility of the appeal that the beneficiary has appealed, and then the facility has to give a written notice to the beneficiary called a detailed explanation of non-coverage, which explains why. Now, this is extremely detailed, and I think it's almost never actually followed. One person told me that he was very knowledgeable about all of these procedures and what the regulation said. The QIO does this, the skilled nursing facility does that. He said, he called the QIO and said, I haven't gotten my detailed explanation of non-coverage. And the person didn't know what he was talking about. He asked for the supervisor and he explained what the regulations say, told her what the form was called, gave her the regulations number. And the supervisor said, oh, well, we don't follow that. So even though the regulations have very detailed language about what is supposed to happen, we're not sure it really does happen all that often. But if you have this happen to you and you know about it, you might be able to persuade the QIO that the facility didn't give you the right notice. So you don't know the detailed reason why the facility believes Medicare coverage is no longer available. Next slide, please. So what the QIO is supposed to do in these appeals, after it will call you, might be by phone, but has to say why it made its decision, what happens to Medicare payment as a result, and what to do for the next level of appeal, which is called reconsideration. Next slide, please. So with the expedited appeal, of course, the problem is it's hard to win without the physician's support or a strong family statement or both. And that's why you want to get that physician letter as early as possible, detailed, specific, and personal about what the resident needs and why therapy is medically necessary. Just saying from the physician, I'm the physician, I order it, it's medically necessary, that won't work. It won't be sufficient. So try to use that template if possible. Next slide, please. So if you win, that is terrific. Medicare covered services continue and there's no break in coverage and you keep moving along. The problem that we have seen is that the skilled nursing facility is very likely to give another notice of non-coverage in a couple of days, sometimes the identical notice of non-coverage. So even though you win, 2 days later, they might start this all over again and say, no, Medicare isn't going to pay anymore. So it's good if you win, especially if the facility backs off and keeps providing care, but it's a problem and you might have to do it again. Next slide, please. So there's a reconsideration process, and I'll go through all those different different levels of appeal, but it's pretty much the same. The notice from the QIO will tell you when to appeal, how much time you have. It's all the same. It's all the same information. You just keep submitting it over and over again with any additional information you have at the different levels of appeal. Next slide, please. So sometimes you might not want to go through the expedited appeal. Sometimes you might. If you do and lose, but the person stays, then what? And you want to see if Medicare will cover the stay that's already happened. You can ask for the SNF Advanced Beneficiary Notice, which is also known as the demand bill. And the purpose of that form is to get Medicare payment for services that have already been provided. Now, what happened in the past is nursing homes would say, well, Medicare won't cover your mother's stay. People thought that Medicare made that decision. The nursing home said Medicare isn't going to cover it. But actually, Medicare has no idea that your mother is in the nursing home. The only way they would know is if the facility submitted a claim for reimbursement. We provided care for Mrs. Smith in the month of February. Here's the bill. We want you to pay it. So one of my colleagues litigated this case, Sarah sat and said, well, the skilled nursing facility has to give the beneficiary a written notice if it believes Medicare Part A won't pay for the stay anymore. And then the person gets to appeal. And until Medicare makes an initial decision, Medicare cannot bill the beneficiary, cannot bill until there's some initial decision. That's the demand bill process. So you do that if you lose the expedited appeal, and still what people will typically do is say, okay, I agree to be private pay at this point, but I want you to give my mother therapy 5 days a week anyway. And if that happens and the person stays, like the man I mentioned before, whose mother was walking out the next day because she had actually improved as a result of her therapy, that's from the demand bill. That's how you get it to work. Those are the people who are most likely to prevail in these cases, people who actually receive the services, all of the covered services and the therapy 5 days a week. Next slide, please. So there are more levels of appeal after this initial appeal, but you will likely be required to pay out of pocket during the continued stay in the nursing home. Next slide, please. Redetermination, this is the next level, has to be requested within 100 days of the calendar days of the initial determination. Submit the evidence. If you get more evidence you want to submit, submit it. The redetermination decision is supposed to be issued within 60 days. Next slide, please. Then there's the reconsideration, next level of appeal. Very detailed. Each level, when you lose, will say, here's how many days you have to appeal. This is where you send your appeal. You submit your evidence each time over and over again with any additional evidence you're able to gather, especially if the person has stayed in the nursing home and continued to get the therapy and improve. That's what you keep presenting. Keep going to the next level of appeal. Next slide, please. Then there's the administrative law judge level. And this is really the important level. And this is where people are more likely to prevail. So one thing that's very important about this is when you get to this level, you want to write beneficiary appeal on the envelope. There has been a tremendous delay in appeals, even though the ALJs are supposed to hear these cases quickly and make rulings, make decisions. They weren't, because they had such a backlog of cases. So we had litigation and the government agreed that if there was beneficiary appeals would go to the top of the list and they would get a timely hearing. They would get a hearing in front of the administrative law judge. And it's an informal process. You can do this yourself and you explain, this is what happened. My mother this is where she was living beforehand. She fell, she had hip surgery. She went to the nursing home, she received therapy. You give detail about what happened and why this should be covered by Medicare. You have a better chance at that level when you get to explain what happened. Next slide, please. After the ALJ level, the next level is Medicare Appeals Council. They don't hear from you directly, they just look at the paper. So whatever paper you have would be submitted to the Medicare Appeals Council and hope to win there. And next slide, the last part is filing a lawsuit in federal district court. So next slide, please. I said that the first way that we will talk about denial of coverage is where the nursing home says Medicare isn't going to pay anymore. It's Medicare's decision. So, it's the nursing home's decision that Medicare will not pay, and that's what you're appealing. A second way that Medicare can be denied is if the facility submits a claim for coverage, they believe that it is covered care, and Medicare denies it. And the way you find out about that is the Medicare summary notice that Medicare sends to all beneficiaries each quarter saying, these are the claims that were submitted for you during the last 3 months. Here's what we did about them. And sometimes here's what you have to pay. Sometimes we denied the claim. And at the end, it says, if you disagree with anything here, circle it and you can appeal. After that, that starts the appeal. But once you get through that, it's the same levels of appeal as if the facility had decided that the person wasn't eligible for Medicare coverage. Next slide, please. So for Medicare Advantage, there's a little bit difference at the beginning, only at the beginning. What Medicare Advantage plans use is something called an integrated denial notice, and that's for denials or discontinuation of coverage. And you can get that form through this link. Next slide. Medicare Advantage enrollees can ask the plan for a Medicare coverage determination, and then the plan has to issue an organization determination within 72 hours if it's expedited, otherwise for standard appeals in 14 days, and 60 days if it's just a request for payment. Next slide, please. But after that initial decision, it's the same stages as for all of the other kinds of appeals, no matter who, whether it was a nursing home that denied coverage or Medicare that disagreed with the nursing home and said, no, we, Medicare, we don't think it's covered care. Same stages, reconsideration, redetermination, ALJ, Departmental Appeals Board, and Federal District Court. Next slide, please. So what I would say the important parts are of this presentation, I hope for you, are that JIMO confirms that residents have the right to Medicare coverage of a SNF stay if they're improving or if they need professional nursing or professional therapy services to maintain function or to prevent or slow decline or deterioration of the resident. You want to try to keep the services in place and provided if at all possible so that Medicare keeps paying and you don't have to pay these exorbitant private pay daily rates, $500, $600 a day, whatever the facilities are asking for. If you are unsuccessful, then we encourage people to use the expedited appeal. Try to keep the services in place that way. Try to submit the letters from the doctor, anything that you could write as a family member or friend about why this person needed care and should be getting Medicare coverage. If you don't win at the expedited appeal, and if the person stays in the nursing home getting covered care, then ask for the demand bill, and that will have Medicare decide. It doesn't matter what happened in the expedited appeal. It's a totally separate appeal. You get another chance to argue, these were Medicare covered services. Medicare needs to pay for them. These are the services that my friend, my relative received. They're covered by Medicare. Medicare should pay. And the point is keep appealing, because the best chance you have of winning is at the administrative law judge level, where you can tell his story, tell what happened, and they listen. They will listen to you and give you a chance to explain why Medicare coverage is appropriate. So next slide, please. We have a lot of information, links on our website for JIMO, for toolkits, for self-help materials. Next slide, please. And this is where I am and how to reach me. And please feel free to get in touch with me if you have an appeal question at any time or questions about Medicare coverage or JIMO. And I will send the other PowerPoint as soon as I get off the phone. I really don't understand why this happened, and I apologize. I mean, it wasn't tremendously different. It's a little bit different, but I want you to use the other one because I just checked all of those links. So you want to make sure that you get that one. But I did send those other letters and the template. So I hope that will be helpful. And I hope I know it's very confusing. I'm telling you, it's confusing to the experts in our office too. But Medicare coverage is possible and it's a good benefit and you should try to get it if you're entitled to it. So thank you.
Thank you very much. I'll turn it over to Jeannie. I think we do have some questions in the chat.
We do have some questions. One of the questions comes from Jay Costello. She asked, do you have any idea how quickly an administrative law judge responds and schedules the hearing?
I think they're supposed to do it in 60 days. It's to happen pretty quickly. And now they're all on telephone. It used to be that you could, I'd go to Staples and have a chat, a video conference. Now it's all on telephone. But I think once it gets to them with that beneficiary appeal on the envelope, they do it pretty quickly. Maybe 60, 90 days. I mean, they might, go over a little bit. And, if it's the facility, if it's Medicare that's denied coverage, sometimes the facility staff will come in and testify on your behalf. They will say, yes, this really should be covered, especially if the facility had submitted this to Medicare. They thought this was a covered service, so they might be an additional witness for you. Sometimes they don't show up at all, and you're the only person at the hearing talking, and that's pretty common too. You're the only person explaining the story. There's nobody there on the other side. Or, sometimes the Medicare Advantage plan can show up, and I think it was the family with that had the therapist article about traumatic brain injury for their son, very tragic case. The Medicare, the person who made the decision for the Medicare Advantage plan admitted at the hearing that that person had not really read the record, read a couple of pages, but not all of it. That was pretty amazing. So, a hearing is an interesting opportunity to tell your story, and maybe nobody else.
For instance,
Another question from Carol Default. Is there something about a 60-day time frame between spells of illness in order to be Medicare covered?
Yes, that's a very good question. A benefit period, the most people can get until the pandemic was 100 days. In order to start a new benefit period, person has to not be in the hospital or in the skilled nursing facility for 60 days total. And then to start the new benefit period, the person needs to go to the hospital for 3 consecutive days as an inpatient, and then within 30 days, go to the skilled nursing facility. So there does need to be that 60-day break. And I think sometimes people will call and say, I'm in the nursing home, I was here for a hip fracture, but now I broke my arm. Don't I get a new benefit period? The answer is no. You have to be out of the facility for that 60-day period. Now, right now, I guess the benefit period, that still exists. What you don't have to do is go to the hospital again during the pandemic, but you still have to have a break for the new benefit period to start up again, unless the person is in the nursing home and the facility requests an additional 100 days because of the pandemic, which sometimes happens. People have to be, test negative before they can go back to their assisted living community. So they are in the nursing home. As long as they're still getting skilled care, they could have more time. But the break is a real problem with Medicare.
Toby, a third question. Does the resident or their power of attorney have to sign they agree therapy is stopping 48 hours before it does stop? And what if they don't?
The facilities can ask people to sign, but I don't think there's legal significance to that. The facilities have to, or required to give notice at least 48 hours in advance. They're required to do that, but I don't think there's an obligation on the part of the resident to sign and say, I agree. Not agreeing, you're saying I want to appeal. So no, you don't have to sign anything.
Okay. Another question, can therapy write orders?
Can therapy write orders?
Carol, do you want to clarify that a little?
Hi.
Huh?
Yes, so I'm wondering,
There she is.
yes, I came, I'm here. I'm wondering, if therapy is allowed to write like physician orders, like dietary can write some orders. So can the therapist write, well, I'm going to DC Mr. Smith here without even like really checking with the doctor?
I think the requirements of participation, which are the standards of care that nursing homes have to meet to be in Medicare and Medicaid, the Obama administration wrote revised requirements in October 2016. And I believe there is something in there about therapists having authority, but they can write orders, but there has to be a connection to the physician. I mean, it's under the general supervision of the physician. They can't just do it without the physician. But I think in reality, it's what you're saying, that the physicians defer to the therapists. That can be a problem. And I think even though the law and regulations have always said that people can have whatever physician they want, it's a free choice of provider, don't have to have the facility physician. In reality, what happens a lot of the time is that the physician who's providing the medical care for the resident is often the medical director, who's then the attending physician for many of the residents. And so they're less likely to disagree with the therapist. But you do have a right to have, your own physician give orders. And I know sometimes families have tried to get another therapist to come in and do an assessment and, have that written up and submit that as why a person needs care. But I think the regulations allow therapists to do orders under supervision of the physician, whatever that's supposed to mean.
From Sheldon Sports, the issue with the observation status, is there any appeal rights to the determination by the hospital that the consumer is under observation status?
No, when CMS issued the regulations for the Notice Act and created the MOON, they amended the regulations to say explicitly no appeal right, which was pretty appalling. So there is no formal appeal. And I think people try, you try to argue with the doctor about, why I need to be an inpatient, not an outpatient. I think a lot of doctors don't really even know. They have no idea of what the consequence is, that if you don't have the 3-day inpatient stay, Medicare won't pay. But remember, right now during the pandemic, there is no requirement for the 3-day stay. And I know that not all nursing homes are aware of that. So I'm not sure it's in this version of the PowerPoint, but in the other version of the PowerPoint, I do have a link to the CMS guidance. This was back when the pandemic first started. They were worried about having hospital beds available for people who had COVID-19, and they wanted people to get out as quickly as possible. So it's been in the guidance, in the waiver guidance for a year now, almost a year. But there is a link in the other PowerPoint.
The second 100 days, this is from Peg, and straighten me out here if I'm wrong. This is the second 100 days at a skilled nursing facility. Is that to relieve the increased demand for hospital care during the pandemic?
Well, it was done at the same time by CMS. It was, a year ago, and I think that was the concern. But I think there was also, recognition that that people can't necessarily leave, especially more recently, people can't leave the nursing home like to go back to assisted living until they have negative tests or 2 negative tests. So, but the problem with both of these is that they're initiated by the facility. There is no particular way that the resident can ask for it. So we do have this toolkit for the 100 days and what to do. One of my colleagues wrote that. And so we have a link to that. You can find it and see, there's a decision where somebody was able to somehow get to an administrative law judge and prevail. And there's other information in that toolkit to try to help you persuade the facility that they should be extending it. You know, it's what's very odd to me is why facilities are stingy with Medicare coverage. You know, of all of the payment sources, the highest payer is Medicare. Traditional Medicare in particular pays the highest. And in fact, when the new reimbursement system came into effect October 2019, it was supposed to be budget neutral. But in fact, it's paying $200 a day more. So nursing homes typically now for Medicare alone are getting about $640, $660 a day. Now there are different categories and it depends, but that's the average. So that is a really high rate. $640 a day is very, very high. The second highest rate is Medicare Advantage. It's about $100 a day less. And then typically private pay and then Medicaid. So considering that Medicare is their highest payer, it's sort of weird that they aren't more generous in saying, okay, you need this coverage to maintain function. You know, you need this to function at your highest possible level.
Kay Tyberg has a comment. If the personal care physician is the nursing home's physician, doesn't this affect the outcome of getting support?
Well, I think that's right, because they're not going to, you know, if they are on the payroll of the nursing home, that becomes a little bit more difficult to take an independent stance, which is why, you know, sometimes people will talk to the primary care physician in the community. Sometimes the resident has had a physician in the community. Like we know that community physicians don't follow patients into the hospital. It's the hospitalist who does it and who provides care, medical care in the hospital. But if somebody has a primary care physician who's known that person for a long time, you know, sometimes the physician could come in and see the resident. Why not? People, well, until the pandemic, right? That's why not. Nobody comes in now, but people would, you know, if you can get the primary care physician or the surgeon who did the hip surgery might say, look, this is what my patient needs. You know, my patient is not weight bearing now, can't do physical therapy, but I want occupational therapy because she's got to maintain upper body strength. And then after 6 weeks, when the person's weight bearing, then, you know, we'll shift to an improvement mode. But, you know, you want to get some physician, if at all possible, to write a letter for you, draft a letter.
One of our participants noted that they have tried to contact the PCP without success.
Yeah.
I did suggest, she says she's called numerous times without success. I did suggest to her that she make an appointment with her loved one's PCP. I hope that will help you, Dorothy. I think it's a matter of time. You know, they don't have time to talk to somebody on the telephone.
Yeah.
Without getting money in return.
Yeah. It can be a problem.
I think that.
Okay.
Oh, there's another note here from Carol. Carol, I think that we've answered that question, that Toby has answered that about the toolkit that is available from the Centers for Medicare Advocacy.
You know, I am so appreciative that you are on tonight because it's just so timely. I had a lady call me yesterday that is experiencing, you know, issues with her spouse. They didn't give her any notice yet, but they're saying they think that the therapy is going to have to stop. So, but he's got so much going on medically. So she couldn't be on tonight. I told her I'd take notes, but I really appreciate that you're going to share all your information too.
Sure. Well, you know, it's easier to qualify with therapy because if it's 5 days a week, that's pretty straightforward. But If somebody has a lot of medical conditions, a lot of complications, then you can prevail if the person needs skilled nursing 7 days a week. And one thing that's difficult is that a lot of care is provided by the certified nurse assistants. And even though they're really important people, for this purpose, it has to be the healthcare professional, the registered nurse. So if you look at a whole variety, get copies of various records, nursing notes, calls to the physician, if their medication is changing a lot frequently, or if the person, they're trying to observe changing condition is one thing. So if you see a lot of changes in medication, that could be a lot of skilled nursing involvement. And as some of those sections of the manual show, even if the person ordinarily, even if the services aren't skilled, if the person's unique combination of medical conditions and needs means that a skilled nurse, a professional nurse, must provide the service, then it can become skilled and covered by Medicare, even though the services themselves are not. So it's a very individual determination based on everything you can say about that person, which is why, why we think that a lot of families can do this very well, because who knows the relative, who knows the resident better than the family? So to explain not the medical conditions, but this is what my mother needs. This is what's happened to her in the past. This is what's going on. I mean, families can do this. And then, doing these appeals, if you get more evidence, if you get something else, you just keep submitting it till you get to the ALJ where you have a better chance of winning.
Well, I think this person has a very good case. I don't want to monopolize the time, but he just had a recent amputation. So he needs the nurse to do the dressing changes, plus he needs the therapy. So I think if she chooses to pursue it, she has a very good situation that she might win.
Yeah, so I'm just pulling up our Medicare handbook that we revise every year. And let me tell you, to show skilled nursing care. So the therapy I said is very straightforward, but for nursing care, there are 3 ways. One is overall management and evaluation of the care plan. Now you can see that the language is a little bit weird. Managing and evaluating a care plan is skilled nursing services when the skilled personnel are required, quote, to meet the patient's needs, promote recovery, and ensure medical safety. That's the language. That's pretty vague, right? You've got to make the argument. Medicare coverage is available for this component, overall management and evaluation of care plan, quote, only when, in light of the patient's condition, the aggregate of those services requires the involvement of technical or professional personnel. So they have an example in the Medicare Benefit Policy Manual that skilled personnel are necessary based on the patient's condition, age, and immobility, which together create, quote, a high potential for serious complications. So you've got to make the argument about based on the facts. So the second way, besides overall management and evaluation of care plan, is observation and assessment of the patient's changing condition. So if treatment has to be modified, or new procedures need to be done, or the patient needs to be stabilized, the patient is not stable coming out of the hospital, then that would qualify as observation and assessment of the patient's changing condition. So the regulations have an example of a person who has congestive heart failure, who requires close nursing observation, and then here's the language of the regulation, to detect signs of decompensation, abnormal fluid balance, or adverse effects from medications. Then a person who has psychological symptoms in addition to physical problems such as depression, anxiety, agitation, may require skilled nursing care to ensure safety or the safety of others. The example, so that's the second type, observation and assessment of a patient's changing condition. And the third is patient education services, to train and teach patients self-maintenance and how to manage their treatment regimen. And of course, one of the examples is a recent leg amputation. If you have to learn, you need gait training, how to teach care of a prosthesis, or a newly diagnosed diabetic patient who needs skilled personnel to teach self-administration of insulin and foot care precautions. So that's usually not, this patient education isn't as common, but it's certainly relevant for somebody who has a new amputation. Absolutely a basis for skilled nurse. So it depends, it depends upon the person. If the person has other things, other medical conditions besides the new amputation, that shows that the skilled nurse has to be doing this.
Thank you.
Thank you so much.
I think that that's everything that I have under chat.
Yep, and I don't see any hands up, so thank you so much, Toby. That was so much information.
I know, it's so confusing. I tell you, when we were dealing with the expedited appeal and the standard appeal, and I said to our expert, well, if you lose the expedited appeal, why exactly would you go to the next level? She said, well, it doesn't really make sense. We don't know. But we know sometimes the administrative law judges are dealing with the expedited appeal. People keep going through that one as opposed to the demand bill process. And then the administrative law judge says, okay, you win, the Medicare covered services. But that's really not what the judge was supposed to be deciding. In the expedited appeal, the judge is just supposed to be deciding whether the person was eligible for coverage, not whether the person received the services. So there's a lot of confusion, but I think, if you realize that people are entitled to Medicare coverage to maintain their function, to be able to live it their best possible way and keep appealing. Don't give up, because you can win these cases, and it's important. I mean, people are entitled to their Medicare coverage. So
Absolutely. Thank you so much. We look forward to getting that other PowerPoint and sending it out to everyone.
I should have noticed this. I don't know why. I don't know how this happened, but in any event, because we switched. I mean, when I saw blue, I should have registered, like at 4:15. Wait a minute, that's not the right. What is this? But I mean, it's pretty much the same, but use the new one because I checked all those URLs. And
Absolutely.
there's some other things. All right.
We'll send that
Okay.
out tomorrow morning, everybody. So they'll
Yeah,
get
and
that.
also those letters and the template could be very useful for people.
Absolutely.
Thank you so much.
Thank you.
Sure.
All right. And just to finish up our meeting, some of our upcoming meeting topics, we're going to continue our advocacy toolkit next time. On March 23rd, we're going to hear from Jessica Lippert. She's the regional apprise coordinator. And then on April 6th, we're going to hear from Janice Minert. She's at the Pennsylvania Health Law Project. And then we're still working on our last April date there. So we'll be sure to get something good for you. And as always, thank you for attending this evening. If you have any specific concerns or complaints, please reach out to the State Ombudsman Office at 717-783-8975 or by email at ltc-ombudsman@pa.gov. So thank you, everyone. Have a fabulous night. Enjoy the warm weather, and we'll see you next time.